Hi, everybody. Welcome back to week 11. This week in module 11, we are focusing on the endocrine system. So again, this is a focused review and summary. Please use this as an additional resource to the other PowerPoints that are already posted on, within the module. These particular points that I'm bringing up in this module are just key points that I wanted to bring to your attention, as well as have you focus on for your boards, as well as your next exam. So please utilize this as a resource. And again, I'm going to stress this when it comes to preparing for your exam, please do focus on your the focused exam outline that I provide. Please make sure you use that to your advantage because it really does encompass what I have on the exam. All right, so here we go. So endocrine disorders have been on the rise both in the US and worldwide. Diabetes mellitus is the most common endocrine disorder, followed by thyroid disorders. In the US, the prevalence of diabetes has been accompanied by an increase in obesity and prediabetes, as we know and we see. Remember, obesity is an epidemic in this country. The CDC reports as of last year that 20% of every population in the US, of every state, 20% of every population of every state in the US is obese. So it's a big deal. It's a big deal. It's a big issue. And as nurse practitioners, it is our role to make sure we are promoting lifestyle changes, good nutrition, and just making the right decisions for our patients to make sure they're going in the right direction, because obesity obviously can have such a toll, as well as diabetes. Practitioners need a good understanding of the homeostatic functions of the endocrine system and the consequences of endocrine dysfunction. So in this PowerPoint, I'm just going to go over the anatomy and physiology of the endocrine system, just to review the basic functions, just to make sure we have the basis overview of the endocrine system, just to review. And then we're going to follow through with the adrenal glands and the gonads, the thyroids, and then metabolism and the pancreas are reviewed. Each block addresses the normal physiologic functioning of the gland, mechanisms of the hormone function, and disorders of the gland. So here we go. So here I just want to watch a short video on YouTube to review the endocrine system and just go over the basic overview of the hormones, just so we're very clear on that. Here we go. It's only 13
Professor
minutes.
Dave here. I want to tell you about the endocrine system. He knows a lot about the science stuff. Professor Dave explains. We've already looked at a few systems, those being the skeletal system, muscular system, and nervous system. So we are starting to comprehend how the human body works. And with that, we are bridging the gap between a single cell and a complex multicellular organism. But we still have a number of systems to go. And the next one up is the endocrine system. This interacts with the nervous system in order to control the activity within all the cells in the body. So let's take a look at how this works now. The endocrine system is comprised primarily of glands, which are organs that secrete a particular compound. This compound acts as a messenger, traveling throughout the bloodstream and delivering that message to cells all over the body. These compounds are called hormones, and the messages they carry may tell cells to start dividing or to start synthesizing a particular protein, whether their target is a particular tissue or if they simply act as intermediaries that communicate with other endocrine glands. We already examined how these compounds interact with receptors in the plasma membrane of a cell and the chemistry that occurs as a result, which will elicit an appropriate response within the cell. So for more information on that, check out some of my biochemistry tutorials. Here, we will focus on the organs of the endocrine system and their specific functions. The organs of the endocrine system are very small and scattered around the body. These endocrine glands differ from the exocrine glands that produce sweat and saliva in that these ones produce hormones, which are typically released into the bloodstream. These glands include the pituitary and pineal glands and the hypothalamus, all of which are parts of the brain. Then there are the thyroid and parathyroid glands found in the neck in front of the trachea. Next, we have the adrenal glands and the pancreas, which are in the lower torso, as well as the gonads, which are called testes for a male and ovaries for a female. Other organs also contain clusters of endocrine cells, like the small intestine, stomach, kidneys, and heart, as these also secrete hormones at certain times, though it is not their primary function. These structures map out the major hormonal axes of the body, those being the hypothalamic pituitary adrenal axis, which regulates cortisol, and the renin angiotensin aldosterone axis, which helps to regulate sodium, potassium, and water balance. Those are the organs of the endocrine system. So what are the hormones they produce? We mentioned a few of them just now when describing the hormonal axes, and these typically belong to one of just two categories. The first kind are amino acid derived or small proteins, and the second kind are steroids. Both of these are types of molecules we learned about in the biochemistry series, in case you need a little review. Any of these hormones are secreted by glands when they encounter certain stimuli, and these can be of three varieties. Humoral stimuli involve changes in the concentrations of certain components in the bloodstream, like particular ions or nutrients. Neural stimuli involve stimulation by nerve fibers. And hormonal stimuli involve interaction with other hormones. So sometimes a hormone will interact with a gland, and as a result, the gland will secrete some other hormone. These hormones can elicit the intended effect in even very low concentration, and they circulate in the blood either free or bound to a protein carrier, depending on their solubilities. So let's go through each gland now and highlight key aspects of their function, starting with the pituitary gland. This is a small sac comprised of a posterior lobe and an anterior lobe, which hangs from the hypothalamus via the infundibulum. This gland secretes at least 8 hormones. In the posterior lobe, these are neurohormones that arrive ready-made from the hypothalamus, while the anterior lobe secretes its own hormones. The neural connection between the pituitary gland and the hypothalamus is called the hypothalamic hypophyseal tract, and the two main hormones that travel through here to be secreted by the posterior pituitary are called oxytocin and antidiuretic hormone, or ADH, also called vasopressin. Oxytocin is released during childbirth and is also involved in the release of milk during breastfeeding. In addition, it is involved in sexual and affectionate behavior between mates, promoting couple bonding. ADH is completely different, inhibiting urine formation during times of high blood osmolarity or low blood pressure, thus helping the body avoid dehydration. The anterior pituitary has a different role, manufacturing and secreting a variety of hormones that in turn regulate other endocrine glands. These hormones are growth hormone, which promotes tissue growth and directs cells to metabolize fat, thyroid stimulating hormone, which stimulates the thyroid gland, as one might expect, adrenocorticotropic hormone, which stimulates the adrenal cortex, follicle stimulating hormone, and luteinizing hormone, which regulate the gonads, and prolactin, which stimulates milk production in females. Any of these can be released when a particular stimulus is received from the hypothalamus. Next, let's look at the thyroid gland. This is comprised of 2 lobes connected by the isthmus, and it produces thyroid hormone, which is actually 2 hormones, thyroxine and triiodothyronine, also known as T4 and T3 respectively. This is a hormone that affects almost every cell in the body by increasing metabolism, regulating tissue growth and maintaining blood pressure. Next up are the parathyroid glands, of which there are typically 4. These secrete parathyroid hormone, which regulates calcium and phosphate levels in the blood. Then there are the adrenal glands, which are each comprised of an inner adrenal medulla and an outer adrenal cortex. The cortex synthesizes a wide variety of steroid hormones called corticosteroids. Mineralocorticoids, like aldosterone, regulate ion concentrations like sodium and potassium. Glucocorticoids, like cortisol and cortisone, influence metabolism by keeping blood glucose levels consistent. And they also maintain blood pressure by influencing vasoconstrictors. Cortisol also triggers gluconeogenesis, where glucose is made from fats and amino acids. And gonadocorticoids are sex hormones, like androgens, which are typically converted into testosterone. The adrenal medulla, on the other hand, synthesizes catecholamines like epinephrine and norepinephrine. These are important in emergency situations, so the perception of danger triggers their release, upon which they induce high levels of glucose in the blood and a faster heartbeat, which are good for evading danger. Finally, there is the pineal gland, found in the diencephalon of the brain. This produces melatonin, which helps us sleep. That wraps up the glands that are devoted solely to endocrine function. There are a few other organs to mention, however, starting with the pancreas. This is found in the abdomen, and it is responsible for making the hormones glucagon and insulin. These regulate blood glucose levels. Glucagon is a polypeptide made of 29 amino acid residues, which will stimulate an increase of glucose in the blood. Much of its activity occurs in the liver, where it triggers breakdown of glycogen and glucose synthesis by other means, as well as the release of the resulting glucose. Insulin is a larger peptide made of 51 residues, qualifying as a small protein. This will stimulate a decrease of glucose in the blood by inhibiting glycogen breakdown and glucose synthesis. So glucagon and insulin have nearly opposite actions in the body, as glucagon release is triggered by fasting and insulin release is triggered by eating. Finally, the gonads produce sex hormones just like the adrenal cortical cells. The ovaries produce estrogens and progesterone, which control the development of reproductive organs and secondary sex characteristics in females. The testes produce testosterone, which controls the development of reproductive organs and secondary sex characteristics in males. The placenta is a temporary endocrine organ which exists during fetal development in a pregnant woman. It secretes steroid and protein hormones that influence pregnancy and support the development and growth of the fetus. Lastly, there are other organs that also produce hormones. Adipose cells release leptin, which communicates how much fat is stored in the body, as well as resistin and adiponectin, which are related to response to insulin. Enteroendocrine cells in the gastrointestinal tract release peptide hormones that regulate digestion. The heart has cells that secrete atrial natriuretic peptide, or ANP, which regulates blood volume and blood pressure, as well as B-type natriuretic peptide, or BNP, in response to stretching caused by increased blood volume. The kidneys secrete erythropoietin, which promotes red blood cell production, as well as renin, which is associated with aldosterone release. Bones can secrete osteocalcin, which promotes the release of insulin. The skin produces cholecalciferol when exposed to a type of ultraviolet light, which is an intermediate in vitamin D production. And with that, we have completed a basic introduction to the endocrine system and all the glands and hormones that are part of it. This remarkable system of communication is critical for human development, and our bodily functions depend on the ability of hormones to travel everywhere they need to go. As we said, hormones travel through the bloodstream. But what is blood exactly, and how does blood circulate around the body? Let's move forward and learn about this incredible system next. Thanks for watching, guys. Subscribe to my channel for more tutorials. Support me on Patreon so I can keep making content. And as always, feel free to email me, ProfessorDaveExplains@gmail.com.
All right, guys, I know that was like a longer movie than I normally would post because I try not to post anything more than like 10 minutes because it's too much for my brain. But I like this guy, Professor Dave. I think he keeps it very simple. So I would encourage you to reach out to his and subscribe to his channel just to get more videos to help understand and grasp like basic concepts. Remember, I always reiterate like, advanced pathophysiology. Okay, great. We're at an advanced level of education and we're graduate students now. And now we need to understand things at another level. But that doesn't change the fact that we need to always remember to bring it back to the basics and review the basics in order to, progress forward and understand concepts at a deeper level as we progress forward with our clinical practice. All right. So endocrine concepts. So here we are with the hypothalamus, pituitary, and adrenal glands. So one of the things I just wanted to definitely focus in on was the action of hormones. So things we need to make sure we're understanding and reviewing. So action of hormones. So negative feedback works to suppress the secretion of hormones, while positive feedback stimulates hormone production and secretion. So understand negative feedback versus positive feedback, okay? Understand the estrogen's influence on oxytocin. So remember, increasing estrogen levels influences oxytocin, where it is to be transported to the posterior pituitary gland for secretion. Okay, SIADH and this serious pathophysiological effect, it includes water excess, which dilutes sodium, causing hyponatremia. And then we have Addison's disease and its clinical manifestations of salt cravings, hypotension, and fatigue. Remember, that's caused by the lack of aldosterone, which leads to hyponatremia and hyperkalemia. All right. And then over here, we have the diagram of the Addison's disease. Okay. Remember, in Addison's disease, adrenal glands do not produce sufficient steroid hormones. So in skin, we'll see hyperpigmentation, low blood pressure, weakness, weight loss. GI symptoms include nausea, diarrhea, vomiting, constipation, abdominal pain. And in the skin, we definitely start to see symptoms of vitiligo, where you have a change of the skin with white patches. All right, next we're going to get into thyroid glands. Again, very, very basic review. The big thing I want you to remember with thyroid glands is the impact of low thyroid hormones versus the impact of low thyroid hormone levels versus high thyroid hormone levels on different tissues in the body. So keep in mind, in general, thyroid hormone increases basal metabolic rate by increasing the production of ATP in many tissues. Remember, ATP is adenosine triphosphate. So this also includes heat production. So thyroid hormone decreases cholesterol and serum lipids. It stimulates fat breakdown, but can also stimulate fat synthesis. Thyroid hormone also influences carbohydrate metabolism in the liver, adipose tissue, skeletal muscle, and pancreas. It stimulates bone growth and development, along with muscle energy expenditure and insulin sensitization. Thyroid hormone impacts the cardiovascular system by increasing cardiac output and causing chronotropic and inotropic effects, and it decreases systemic vascular resistance. In the brain, it maintains normal nervous system function and regulates the synthesis of pituitary hormones such as growth hormone and thyroid stimulating hormone, TSH. Thyroid hormone promotes skin integrity and normal development of the nervous system. And here is another video. I put a couple of videos in this particular review PowerPoint because some of the things in this module are so important and so vital for you understanding just the basic concepts in order for you to really apply it to your clinical practice. And that is the one big thing I found that I missed while I was in grad school, that there were certain basic concepts that I wasn't grasping, and it made it very difficult to move on as I progressed through my education. And I didn't realize it until I started studying for my boards that I missed some very simple concepts in my patho classes or my health assessment classes. Like there were a few classes that I missed some really basic things within different body systems that I wanted to make sure that I reiterated, whether it's in patho or FNP, whatever it is, just to make sure you're grasping these concepts so that it applies to your other classes as you go forward in your education, specifically in pharmacology and in FNP2, where a lot of this stuff is going to apply clinically, not only FNP2, but your actual clinical practice. So here is a video really just reviewing the thyroid hormone function, which is really important so that you can understand the concept between hyperthyroidism versus hypothyroidism. So here we go, guys. It's only about 6 minutes.
Thyroid hormone regulates a variety of physiological and developmental processes.
These are the two big thyroid
like
hormones,
metabolic
T3,
rate
T4.
and neurological, bone, and muscle development. Too much leads to increased heart rate, fatigue, and weight loss, just to name a few. Too little leads to facial swelling, weight gain, slow speech, and dry skin, amongst other things. Not enough thyroid hormone during embryogenesis or postnatal development results in intellectual disabilities, impaired motor function, and short stature. Thyroid hormone controls these functions by regulating the expression of genes involved in these processes. This is known as genomic regulation, and it's the topic of this microlesson. Thyroid hormone includes triiodothyronine, or just T3, and thyroxine, or just T4. Now, while T3 and T4 differ by only one iodine molecule, their biological activities differ significantly. Of the two hormones, T3 is considered the more biologically active because T4 has a higher binding affinity to plasma proteins, which lowers the concentration of the unbound form, and T4 is immediately converted into T3 as it enters the target cell. And finally, T3 has a significantly higher binding affinity to the thyroid hormone receptor compared to T4, which occurs inside the cell. This means that T3 and T4 must first enter the cell before mediating their effects. Thyroid hormone is taken up by target cells in the same way thyroid hormone is transported out of the thyroid gland, and that's by the monocarboxylate transporter. There are two main types of monocarboxylate transporters involved in thyroid hormone transport. They are type 8 and type 10. Besides differences in tissue expression, little is known about their functional differences. However, animal studies suggest that type 8 plays a more significant role in thyroid hormone transport than type 10. This is consistent with the observation that type 8 deficiency has elevated serum T3 levels and results in neurological developmental delays, while type 10 deficiency is not linked to elevated serum T3 levels or developmental delays. Following uptake, T4 is immediately converted into T3 by deiodinase, which is an enzyme that removes the iodine molecule from the tyrosyl ring. There are two classes of iodinases. The 5' 3' deiodinase removes an iodine molecule from the outer tyrosyl ring and produces T3. The 5' 3' deiodinase removes the iodine molecule from the inner tyrosyl ring and produces the biologically inactive RT3. Also, there are two types of 5' 3' deiodinases. The type 1 is found in the thyroid, liver, and kidneys and generates most of the circulating T3, while the type 2 is found in the pituitary, central nervous system, and placenta, and it generates the T3 in those tissues. These differences in expression play an important role in how and when thyroid-stimulating hormone is synthesized and secreted from the anterior pituitary. We'll talk more about that in our microlesson titled Hypothalamic Pituitary Thyroid Axis. Earlier, we said that T3 exerts its effects through genomic regulation. This process starts when thyroid hormone receptor binds T3 to form the thyroid hormone receptor complex. Together with the retinoid X receptor, they bind the thyroid response elements, which are located within the promoters of target genes. Promoters represent specific DNA sequences that lie upstream of the transcriptional start site. By binding specific proteins like hormone receptor complexes, transcription factors, and cofactors, promoter elements influence the transcription of the downstream gene. Binding the T3 thyroid hormone receptor complex and retinoid X receptor to the thyroid response element of target genes can activate or repress the transcription of genes that regulate basal metabolic rate and development. Thyroid hormone target genes include those that regulate the metabolism of fat, protein, and carbohydrates. For example, thyroid hormone upregulates the expression of enzymes involved in gluconeogenesis and enzymes that increase the supply of substrates for gluconeogenesis, like amino acids and glycerol. It increases amino acid levels by regulating proteases that break down proteins, and glycerol levels by upregulating lipases that cleave the glycerol from triglycerides. In addition, thyroid hormone-dependent increases in metabolism of fat, protein, and carbohydrates are paralleled in the upregulation of genes involved in increased oxygen consumption and cell activity. Besides regulating metabolic rate, thyroid hormone also plays a role in neurological, skeletal, and muscle development during embryogenesis and postnatal development. For example, thyroid hormone influences neurological development by regulating the expression of genes involved in myelination, neuron differentiation, migration, and signaling. It also influences skeletal development by regulating the expression of genes involved in the rate of bone maturation and linear growth, matrix degradation, bone formation and remodeling, matrix production, cell differentiation, and clonal expansion. Thyroid hormone also regulates muscle development during embryogenesis and postnatal development by regulating the expression of genes involved in the fusion of myoblasts, the formation of new fibers, and the fusion of new myoblasts to existing fibers. In conclusion, knowing how the thyroid hormone is transported into target cells, how it's converted to the active form, and how it binds the promoter region of target genes, and what processes it regulates, represents a critical step towards being able to diagnose disorders involving thyroid hormone.
All right, guys, hopefully this was helpful. I know it was a little tedious to listen to all these details, but again, the thyroid is so important in your practice in terms of understanding the baseline of it so that you can really treat and really grasp the pathophysiology of hypo and hyperthyroidism. All right. So the next thing we're going to talk about is the gonads and the hormones produced by the gonads. I have another short video, but the biggest thing I really wanted to make sure we review and talk about in this review is the impact of aging on either the male or female reproductive system. Keep in mind in the female reproductive system, aging changes the functioning through menopause, again, hormonal changes. And initially, the follicle stimulating hormone FSH and estrogen levels are variable in menopause. Then the levels of estrogen and fall, while FSH and the luteinizing hormone levels will increase. So age-related changes within the male reproductive system include erectile dysfunction and prostate disorders, which we will get into later on in this presentation. But here I just wanted to, again, bring back a basic review of the hormones produced by the gonads, and just make sure we're very clear on that before we try to progress into the advanced pathophysiology of what we need to grasp as nurse practitioners.
In this video, we are going to talk about the hormones that are produced by the gonads. So the gonads in males are the testes, and in females, it is the ovaries. So let's look at the males first. The gonads are controlled by the hypothalamus and the pituitary. The hypothalamus regulates the pituitary gland by producing hormones that go into the bloodstream, that go through this portal vessel system. When the hypothalamus makes the hormone gonadotropin releasing hormone, that will signal the anterior pituitary to produce follicle stimulating hormone and luteinizing hormone. Now, both of these hormones will impact the gonads. And in males, there are two cell types in the testes that we're going to look at. follicle stimulating hormone will bind to cells called the Sertoli cells. These are the cells that surround the germ cells that develop into sperm. And so the Sertoli cells are really important for promoting meiosis. Luteinizing hormone is going to bind to cells called Leydig cells. These are the cells that are going to produce testosterone. In males, estrogen is also produced. Some of the testosterone will be converted into estrogen. In females, more of the testosterone is converted into estrogen, but both of these hormones are produced by the Leydig cells in males. Now, if we were to take a cross-section of the testis and look inside, we would find these seminiferous tubules. These tubules are where the germ cells develop into sperm. So all along the outer edge of the seminiferous tubules, the germ cells will start to go through meiosis. And as they go through the meiotic divisions, they will differentiate into sperm. And then they can flow through these tubules and they can go to the epididymis, which then connects to tubes, the vas deferens, that will allow the sperm to be ejaculated out of the body. The Sertoli cells are also inside the seminiferous tubules, and they surround the germ cells. The Leydig cells are found in between the seminiferous tubules in these regions here. These are the ones that make the testosterone. Now, when testosterone is produced, it has a negative feedback regulation mechanism. So testosterone, when it increases, it's going to signal the hypothalamus and also the pituitary gland. When testosterone levels are higher, it will tell the hypothalamus to decrease the production of gonadotropin releasing hormone. It'll tell the anterior pituitary to decrease FSH and LH. How it tells the anterior pituitary to decrease FSH is because testosterone will stimulate the Sertoli cells, and it will cause the Sertoli cells to make a hormone called inhibin. And then when testosterone levels are low, that will trigger the hypothalamus to produce gonadotropin releasing hormone. So the whole regulation cycle is based on negative feedback. Now, if we look at females, it's a little bit different. In females, the hypothalamus also makes gonadotropin releasing hormone. That will also stimulate the anterior pituitary gland through this vascular portal system to produce follicle stimulating hormone and luteinizing hormone. These hormones are going to target different cells in the ovary compared to the testis. In the ovary, this is where the follicles develop and the egg matures. And when the egg is ovulated, it will move through the fallopian tube. It will become fertilized at some point in time while it's traveling down the fallopian tube. And if fertilization occurs, it will implant in the uterus. These follicles have different cell types, and we'll look at those in 1 second, but the follicle stimulating hormone is going to target cells called granulosa cells. These are similar to the Sertoli cells in males that help to promote meiosis. Granulosa cells surround the egg and help to promote the development of the follicle that will lead to ovulation. Luteinizing hormone is going to target cells called theca cells, and these cells surround the follicles, and these are the cells that are going to produce the estrogen. Now remember that males and females both make testosterone and estrogen, and there's more aromatase in females to increase the production of estrogen from testosterone. So females make more estrogen and males have more testosterone, but both have both. So we're going to look at how the follicle develops. In females, we have generally a 28-day cycle where the follicle is going to develop, ovulation will occur, and then we're going to lead up towards menstruation. And this happens approximately every 28 days, and there are varying factors in different females, but approximately. In females, the hormones have a cyclical pattern. So there's periods of time during the cycle when they're elevated and periods of time when they're decreased. So we're going to take a little bit of a look at what the follicles look like inside the ovary and how those cycles occur. Inside the ovary, we have primary follicles. These developed while the female was an embryo. So there's millions and millions of follicles that developed while the female was in embryonic development. And then when puberty occurs, once a month approximately, these follicles will start to develop. And the dominant follicle each month will be the one that fully grows into a tertiary mature follicle, and one egg will be released. So in a normal cycle, we have approximately 14 days from 0 to 14 until ovulation, and then approximately 14 days to start the cycle again. This phase over here where the follicles are developing is called the follicular phase. And the phase after ovulation is called the luteal phase. Now, when the follicle is developing, the oocyte is inside the center of the follicle. The cells that are surrounding the oocyte are the granulosa cells and the theca cells. The granulosa cells are on the inside and the theca cells are around on the outside edge. Now, as the theca cells start to develop, they produce luteinizing hormone receptors. When luteinizing hormone is released by the anterior pituitary, it will stimulate the theca cells to make testosterone, which is converted into estrogen. That estrogen is going to stimulate the growth of the granulosa cells. More granulosa cells are going to stimulate more LH receptors on more theca cells. That will increase the stimulation and the production of estrogen. So the process during the follicular phase, those hormones are regulated by a positive feedback mechanism. So there's more estrogen being produced because there's more granulosa cells and more theca cells. The granulosa cells stimulate the theca cells to respond to the LH. And then the LH is going to stimulate the production of estrogen. And then more granulosa cells grow. And this occurs during that whole follicular phase until ovulation occurs. Once ovulation occurs, which is actually stimulated by a surge in LH, okay, estrogen does not cause ovulation. After the egg is ovulated, now all of those cells, those follicular cells that surrounded the egg, they become what's called the corpus luteum. That corpus luteum is important because it is going to make a hormone called progesterone. So let's just have a look. The egg is ovulated at about day 14. And then the leftover cells are called the corpus luteum. These cells are going to produce progesterone. Progesterone is very important for maintaining the uterine lining in case pregnancy occurs. If the egg is fertilized and then implants, then progesterone will maintain that lining and it will support embryonic development. If pregnancy occurs, progesterone will then be produced by the placenta to continue to maintain pregnancy. If pregnancy does not occur, then the corpus luteum will regress and the cycle will repeat. So I want to point out a couple of cool things. So I'm going to show you a graph of how the estrogen and progesterone increase and decrease during the cycle and how that relates to the follicular phase and the luteal phase. Over here, as the follicle is developing, estrogen is increasing, luteinizing hormone is increasing, and the follicle is developing until ovulation. That is over here, the follicular phase. Estrogen is increasing during the follicular phase until ovulation occurs. Progesterone is not increasing during the follicular phase. Once ovulation occurs and the corpus luteum is formed, then progesterone will increase. Progesterone will increase in case fertilization occurs and the uterine lining needs to be maintained for pregnancy. When ovulation occurs, estrogen will dip down for a short period of time, but then it will also increase a little bit because it helps to maintain the endometrium, which is the uterine lining. Now, at some point, if fertilization does not occur, then these hormones are going to start to decrease. And then here we have a fun little time period right before menstruation called PMS. PMS is premenstrual syndrome, and this is when both estrogen and progesterone are decreasing. Both of those hormones play a significant role in mood. When we decrease both of those hormones at the same time, we decrease serotonin, we can increase moodiness and increase irritability and all those fun things that go with PMS. Progesterone actually plays a really significant role in the production of serotonin. Serotonin is a good mood molecule. So when progesterone goes down, serotonin goes down, which can also lead to sugar cravings, which is why chocolate and PMS are so associated. The last thing that I want to mention is that during menopause, when women reach about the age anywhere from about 45 to 55, this cycle will stop and ovulation will not occur anymore. And then estrogen and progesterone will stop cycling. And then I also want to mention, men don't have a menopause, but they do have an andropause in a sense that androgen levels, testosterone levels do decrease with age, but in a much more gradual way than with women. So in males, after about age 40, testosterone levels continue to gradually decline by about 1% every year. So in both males and females, as we get older, fertility decreases. And here's a summary chart for the hormones we talked about.
All right, guys, hopefully this was super helpful. I found it really helpful to have this review of just the basic anatomy of the gonads and all the different things that it produces. It was only 13 minutes, but I found it to be a lot of information in 13 minutes. So anyway, I normally don't play more than a 5 to 7 minute video, but this one was a really comprehensive one. I would encourage you to watch it more than once, really to grasp all these concepts. Okay, so the metabolism and pancreas. So the thing I wanted to really focus on this is the mechanism of action of anti-diabetic drugs on the system, and the cellular mechanisms of insulin secretion and how they relate to the mechanism of drugs used to treat diabetes. So in here, you see in this diagram, in terms of hyperglycemia and how metformin affects glucose production and that it decreases it, as well as TZDs, and it increases insulin sensitivity. There's a question, just give me 1 second. So the thing I wanted to really point out is that there's a lot of mechanisms on the action of anti-diabetic drugs, and you need to make sure you realize what each one is. All right, and how it operates in terms of the drug itself. So one of the things I wanted to focus in on is, just really describing how these cellular mechanisms work. So I'm going to give you a baseline. Let's just start with a basic: as a meal is digested, how it operates in the blood. So as a meal is digested and absorbed, blood levels of glucose and amino acids increase. Glucose then enters the beta cells by the GLUT2 transporter, and amino acids enter by amino acid transporters. Metabolism of these nutrients increase beta cell ATP production, and the ratio of ATP to ADP increases. This closes an ATP sensitive potassium channel, producing beta cell depolarization and opening voltage sensitive calcium channels. Calcium is the signal for regulated exocytosis of vesicles of insulin. All right, very important to remember that. Postprandial insulin secretion is further enhanced when the products of digestion reach the ileum and the peptides glucagon-like peptide 1 or GLP-1 and glucose-dependent insulinotropic peptide or GIP are secreted into the blood. So let me repeat that just so it makes sense. So we have GLP-1 and GIP, which are secreted into the blood, circulating to the beta cells and promoting glucose-stimulated insulin secretion. Then we have sulfonylurea drugs, or SUR drugs, which are among the first oral treatments for diabetics, right? We know that. So sulfonylurea drugs are one of the first treatments for diabetics. They are insulin secretagogues that bind to the ATP-sensitive potassium channel and cause it to close, depolarizing the cell and stimulating insulin secretion. More recently, GLP-1 agonist drugs have been effective at enhancing glucose-stimulated insulin secretion in a way that is less likely to cause hypoglycemia than SUR drugs or sulfonylurea drugs. So right now, the GLP-1 or glucagon-like peptide 1 drugs have been more effective at enhancing glucose-stimulated insulin secretion without producing the hypoglycemic effects of sulfonylurea drugs. So just keep that in mind. And the other big thing I want to point out in terms of medications for the endocrine system, they change very frequently. There are a lot of there's a lot of research going on in diabetes, obesity. So this information in terms of keeping up to date in terms, and by using that terminology, up to date, like make sure you go to Up to Date, the app, to make sure that you're keeping very, very conscientious with what is the most best up-to-date evidence-based practice treatment plan for these particular patients. All right, the next big thing I wanted to talk about was BPH. Really important, very common issue going on in the world, benign prostatic hyperplasia. So here in this diagram, we have a vision of the normal prostate, versus an enlarged prostate. And it really is, it's just literally enlarged. And keep in mind what an enlarged prostate does. It compresses the urethra. So remember, when you have benign prostate hyperplasia or an enlarged prostate, you're going to have compression of the urethra. So therefore, you're going to have symptoms that would affect the urine, right? So things that we're going to see in somebody with BPH or benign prostatic hyperplasia are urinary frequency, urgency, and difficulty achieving full bladder emptying, and something called nocturia. So when you experience these symptoms in a patient, the next thing you want to look at in terms of being a nurse practitioner and saying to yourself, okay, which of the following is most likely to be performed next in terms of testing? The next test that we would want to perform is a digital rectal exam. Because if we wanted to really fine tune and diagnose BPH, we need a digital rectal exam to do that. Okay, next, prostate cancer, another big thing we need to make sure that you're very aware of and understand the guidelines and the standards of care in terms of evidence-based practice. Again, the reason I'm bringing this up is not only for your next exam, but also to make sure you realize these things are big topics of questions on your boards. And it's not just about your boards, but it's also understanding the guidelines for when you're in practice in primary care. So things I want to make sure you're grasping. So in this diagram, we have a prostate that's normal versus a prostate that has cancer. And here it is. It's not pretty, but obviously you're not going to really see this because we're not surgeons. So what are we looking at in terms of diagnosing prostate cancer? So we're looking at our PSA. So it's normal for all men to have some PSA in their blood. But the thing is, when we start to see a raised PSA level, it can be a sign of prostate cancer. But the things you need to keep in mind is that it can be raised for a lot of other reasons besides just prostate cancer, okay? If the patient has a urinary tract infection or has recently had a urinary tract infection, again, inflammation equals inflammatory, which equals an elevated PSA. Okay, so if we've recently also had a prostate stimulation, recent ejaculation, or anal sex, that could also cause a raised PSA level. Recent vigorous exercise also can cause a raised PSA level. Again, inflammation, anything that causes inflammation can cause a raised PSA level. Other prostate problems such as an enlarged prostate. Okay, so these are all the reasons for the enlarged PSA or the elevated PSA. So if you have an elevated PSA, it doesn't necessarily mean you have cancer, but it does mean it needs to be followed up. Even if you do have a very minor form of prostate cancer, even at the lowest level, and you still have that raised PSA level, again, that doesn't necessarily require treatment immediately. A lot of the times at the very early stages of prostate cancer, we do something called watchful waiting, where we monitor the patient and their PSA levels every 3 months to make sure they're not continually raising, to make sure that, everything stays stable and it's not worsening. So things that you need to make sure you're very aware of in terms of regarding prostate cancer. The one thing I wanted to point out is that the PSA screening guidelines currently focus on men aged between 50 to 69 years of age, but these guidelines continue to evolve. So just make sure you're keeping up to date, literally with the up-to-date app resource or any of your other references that you have, just to make sure that you're most up to date with the current guidelines and the current standards of evidence-based practice. Okay, so diabetic ketoacidosis. So things I wanted to just point out is, what is it? Obviously, you need to know what it is. And then the other thing I wanted to do is make sure we correctly can understand and describe the pathophysiology of DKA, especially in our new patients with new onset type 1 diabetes. So, when it comes to dealing with a new onset diabetic type 1, right? So a type 1, new onset diabetic type 1, what correctly describes the pathophysiology of the diabetic patient in diabetic ketoacidosis, or DKA, okay? So remember, lipolysis increases the availability of free fatty acids in the blood for energy use. So muscle protein breakdown releases amino acids to be used for gluconeogenesis. So both lipolysis and protein breakdown in the muscle tissue occur to provide energy sources during ketoacidosis. Okay, next, another big thing I wanted to make sure we're very clear on, the impact of obesity on glucose tolerance, all right? Remember something very basic. Inflammatory signals, especially cytokines, generated by adipose tissue. And remember, what is adipose tissue? It's fat. Stimulate the release of lecithin, which promotes insulin resistance, okay? Inflammatory signals, especially cytokines or cytokines, generated by adipose tissue stimulate the release of lecithin, which promotes insulin resistance. So important for you to know. And understand the thought process. So remember, insulin resistance produces less glucose uptake and utilization, which increases fat mass. We don't need extra fat mass. So when this happens, this is a problem. Also, with obesity, we have a loss of muscle, which again produces less insulin responsive target tissue. With obesity, we also have something called the loss of motivation to exercise. Big surprise, patients who are obese don't have the energy to exercise. So again, more reason to produce less glucose uptake and utilization. And then of course, the lack of exercise then leads to the obesity. So it's a very circular type situation where if you don't break the chain, it's just gonna keep happening over and over again. All right, guys, that's it for today. There's a lot to this chapter. I'm hopeful that, between this review, the study guide for the exam, as well as the additional PowerPoints within the lecture module, it'll be a good review for you. I appreciate your attention to all of this. I appreciate your willingness to learn and study and put a lot of energy into this. I can understand how much work it is, but you guys are almost there. We're way past halfway, and you're getting through it. So great job. And I will see you next week.